Se especializa en estudiar cómo mejorar la eficiencia tanto en empresas como en la provisión de salud. Espero, vamos a darle la bienvenida. Retsef, thanks for being here. Thank you.
So, good morning, everybody.
No, es bastante.
In Chile. Is it now better? Okay. So it's a pleasure to be here. First time in Chile. I look forward to knowing people in the country. I would like to share with you today some insights and some examples from over 10 years of experience that I had since arriving to MIT in 2006 as a faculty member, working with health systems and trying to leverage operations research and analytics to actually innovate and change these systems. And before I get into the details, I want to highlight or to give you kind of a brief of two major points that I would like to make throughout the examples and the discussions. One of them is to discuss a few very important aspects of what does it really take to make analytics matter in practice. I'm a big believer in analytics and operations research, but I would be honest with you that I think that the current state of affairs, especially in healthcare, many more people talk about analytics than actually use it in practice. And one of the reasons, or one of the most difficult aspects of this is how do you take that and put it in a very complex system and really use it to change the system. So this is where the analytics and the technical aspects need to meet organizational and other cultural aspects, some of which we heard about in the previous panel, and I want to highlight that. So that's one aspect. The second aspect that I would like to emphasize is the potential that I see and the promise that I see in collaborations between academics and large health systems around this area. I think that if you structure it right, there is a very, very promising potential to use that kind of collaboration to accelerate the impact of analytics as an accelerator of innovation in health systems. Okay, so how do I? Okay, so I worked over the last 10 years with many, many hospital systems, large hospital systems, both in the Boston area and over the US, in many, many settings, inpatient setting, outpatient setting, specialty. By now, I believe I kind of have experience with almost any part of the health systems. But today, I'm going to focus on one particular collaboration that I have for over 10 years with Mass General Hospital. I just want to introduce it very quickly. It's an academic medical center, consistently ranked top 3 in the US, over close to 1,000 beds, 48,000 admissions a year, large system that does surgeries, a large system that sees emergency visits into the hospital, but also a large system of outpatient visits, both primary care and specialty clinics. But maybe something that many people are not aware of, MGH, like many other institutes that deliver healthcare services, is far more than just a healthcare delivery system. It's actually a place where a lot of basic research of sciences is being conducted. It's a place where there is a lot of teaching going on, residents and other professionals in the healthcare industry. It does a lot of community service, and you cannot ignore these 3 other missions that the system has as you think about trying to impact it and innovate. The last thing that I want to say about the MGH, this is the largest non-government employer in Massachusetts. It employs over 23,000 employees. So as you change that kind of a system, you not only impact healthcare, you actually impact the entire economics environment of the state. And I think that that's probably true to other settings when you think about how you change healthcare. Okay, so my collaboration with the MGH started about 10 years ago. It started with a great focus on the surgery part of the hospital, and over the last 10 years has evolved to basically cover the entire system. In a second, I will show you all the projects that we have been doing. They really cover the entire system. In the last 3 years, this has been really at the center of the activities of the hospital. It's being funded personally by the president of the hospital. It's being managed by all the senior VPs of the hospital and has major strategic visibility and impact on how the hospital acts and trying to innovate. What were the goals of what we were trying to accomplish here? This is by far, or important to emphasize, this is a research collaboration. There is a goal here not only to change the system, that's of course, but also publish the results and make a dissemination of the results to actually impact more broadly healthcare. And we really focus on 3 aspects: data analytics. How do you actually create decision support tools that help experts make decisions? We are not trying to replace experts. We are trying to support them, and that's very important. Simulation optimization models that gives predictions. These are systems that are very sensitive to change. And one of the things that is key is to be able to predict what will be the impact of a given change before you actually do it. Because the risks of changing the systems is not only the benefits that you can get, but also there are some potential adversarial things that could happen. And then finally, we really want to change things on the ground. We want to create new practices and new systems. This is the work to date. We already implemented multiple projects. You see here things that are already implemented, things that are in active implementation mode. I'm going to talk about a few examples. And there are many things that are currently ongoing projects. And as you can see here, it covers all the parts of the system: inpatient, outpatient, surgery, medicine, procurement, sterilization of equipment, and anything. We're also almost touching every important piece of this system. These are the 3 examples that I would like to talk about today. Each one of them is going to demonstrate some other aspects of what does it take to go from identifying a strategic, systematic problem in a health system through doing the analytics and the analysis, through actually implementing it actually to change on the ground. So I will try to emphasize through these 3 examples different aspects, from the problem definition, through what kind of analytics you have to use, through other barriers that you actually have to consider. So the first example has to do with the MGH Cancer Center. It's again one of the premier centers in the world, has 14 different specialized centers around different conditions of cancer. Has 2 parts. One is a practice part in which patients actually see their doctors and being cared for, get diagnosed, get treatment plans on board. And then there is an infusion unit that is used to actually deliver a lot of the care, a lot of the therapeutic care, particularly chemotherapy infusion. Okay? And our work was focused on that infusion part. In a second, I will tell you more about that. It's a place that sees about 40,000, that delivers 40,000 infusion hours every year. It has 60 chairs, very expensive resource, both in terms of the professionals that actually staff it, but also in terms of the importance of that unit to the revenue of the hospital. Cancer services, cancer treatment is typically one of the most profitable services that in terms of margin that the hospital is actually delivering. So it has an importance from a health perspective. It actually, as you can imagine, cares for the most sickest patients, but also very important financial aspect to the hospital. So what was the problem that was described to us when we started to work on this? If you look on the left and right-hand side of yours, of the slide, you see the utilization of the clinic throughout the time of the day. And what you can see here is that how do I use the pointer? Oh, okay. So what you see here is in the middle of the day, the utilization peaks actually hits the capacity of the unit. In that case, you see a lot of bad symptoms. You see long wait times of patients that are not being able to get their appointments on time. You see overwhelmed staffs. You see potential safety issues. But you also see that the overall utilization of the clinic, if you look on throughout the operating hours, from 7 a.m. to 7 p.m., was actually relatively low. So you have this dissonance between times of the days in which the clinic is overutilized and times of the days in which the clinic is actually underutilized. And overall utilization was actually less than 55%, which is not something that is that great. Nevertheless, the perception among the people in the clinic was that they need more capacity. And that's not an unusual perception of people that work in healthcare environments on the ground. They feel that overwhelmed because what they remember is the peak hours. They remember that they were overwhelmed on that day over those peak hours. They could not manage, they could not deliver care appropriately. There was a great financial pressure also to grow the volume that goes through this clinic. Cancer is the incidence of cancer is going up all the time. There are more patients that need care. There was both clinical and financial pressure to grow volume. So the first thing is, what is the root cause of this? This is actually not an atypical picture in many health environments. And typically, the root cause is that there are inappropriate scheduling practices that starts from how the scheduling resources are being organized and goes through what kind of information stands in front of the scheduler and continues through culturally, how do you deal between the balance between the needs of different patients and the needs of the system to be efficient. Okay? Specifically in this clinic, scheduling is challenging because when you think about an appointment to the clinic, it's actually not an appointment or scheduling of an appointment with one particular resource, but actually with the multiple resources and the scheduling has to be coordinated across all of these resources. Generally speaking, there are two types of visits into the infusion center. One of them is what we call infusion-only visit. And this is a patient that is already on a treatment plan. They only need to come on that day to get treated. But nevertheless, before they get treated, they need to come and get a blood draw to test them whether they are qualified health-wise to actually receive the treatment that is planned. So even for that seemingly infusion-only appointment, you actually need to schedule two actions. One of them is the blood draw, and the second one is follow up on that, conditioning on the fact that you are okay, the infusion. And the infusion time can vary between 1 hour, 2 hours, up to 7 hours, depending on the kind of cancer and the kind of treatment that you get. To make things more complicated, some patients actually have to come to the clinic and not only receive infusion on that day, but actually get the blood drawn, see their doctor, and then only see infusion. And now you have to actually coordinate 3 actions, right? And the second action of actually looking on the physician is dependent on the availability of the physician, when they hold their practice, when they see patients. So that's a problem. And to start with, the organization of the scheduling was such that 2 different teams were responsible, one for scheduling the infusion part, the other one was for scheduling the MD visit part. So even organizationally, that was completely not coordinated. So what was the approach that we took? The first thing that you want to do is to understand what is the objective, right? What are you going to, what is your objective? We put our objective to basically try and smooth the utilization by having better organization of the scheduling resources, as well as scheduling smarter. And as a proxy of smoothing the utilization of the clinic over the time of the day, we actually choose to focus on minimizing the maximum daily utilization. If you think about the cost involved in staffing a clinic like that, it will really be dictated by what is the maximum utilization. You need to staff enough nurses, you need to have enough chairs, you need to have enough pharmacists, you need to have enough equipment to actually support the peak utilization. And most of this is basically fixed cost. Once if the peak is very high, and it doesn't help you that in other times of the day, the peak is actually, the utilization is very low. You still have to stop for the peak. And that's a very common reason or root cause for waste. Now, the first thing that you need to do is really shadowing and understanding the process. I described to you some of the insights that we got based on that. But after that, you actually need to know what is the price on the table. Is it worth investing time in this, right? Do we have the potential to improve things? And in order to do that, we took what we call a retrospective approach. What does it mean? It means that let's assume that I know in advance what are all the appointments in a given day. And I have retrospectively the ability to change the timing of all of these appointments the way I wish in order to minimize the peak utilization. How better I can do from the current state? Now, this is cheating, right? This is cheating. I don't know all the appointments in advance. In fact, patients are coming one by one, and I have to schedule them as they come, right? But nevertheless, it gives you at least an estimate of what could be the benefit, okay? And moreover, what we were hoping to do, that this will also give us an insight of how a realistic, real-time algorithm that actually schedules patients as they come, one by one, how or what are the set of rules that this kind of algorithm should actually employ, okay? And then, of course, we wanted to implement, okay? So in order to do the second step here, the retrospective piece, we used a technique that is called integer programming, that we actually solved for every day, looking on all the different constraints that you have to respect here. There are capacity constraints. There are, as I told you, coordination constraints between different resources. You can actually build a computer model using a technique that is called integer programming to actually run it and solve it for every day over a year. And the results were quite striking. This is, again, the purple is the current utilization. The yellow is what I could achieve if I would optimize it retrospectively. So this is still not achievable necessarily, but it tells you that potentially you can increase the peak utilization by about 20 chairs, guys. That's like over 30%. That's about 30% decrease in the peak utilization. That's kind of dramatic. That makes it very worthwhile to think about what you can do to actually get there or get close to there, okay? Now, moreover, when we looked on the solutions, the retrospective solutions, we actually got good insights about how a good scheduling policy should look like. And we developed, as a result, a real-time algorithm that scheduled the patient now in a realistic manner as they come. There are many rules to that algorithm, but I want to give you a sense of one thing, or one aspect, one rule that algorithm employed. So what you see here, assume that you're a scheduler, and what you see here is the time of the day, and every half an hour, what you see here is how many patients are currently scheduled to be treated at that moment, at that time of the day, okay? So currently the peak utilization is 5, okay? Starting in the morning, you have 4 patients scheduled, then later 3, and towards the end of the day is maybe 2 and 1. And now you're faced with a request to schedule a new appointment that requires both an oncologist visit as well as an infusion time of 1.5 hours. So the first thing that you do is you look on all the feasible places that you can even consider having that appointment, okay? And then what you're trying to do, you're trying to do 2 things. You're trying not only not to increase the peak, but actually compare the global peak with the local minimum that you have in each one of these intervals. And if that difference is big, that means that this is an area where compared to the peak, you currently have a valley. So that should guide you to prioritize an area like that where the difference is 3 versus an area like the other possibility when the area is 1. And essentially, that's going to be the decision. The decision is going to be to schedule it where the valleys are. So essentially, not only the algorithm is trying not to increase the peak, it actually is trying to balance the load by decreasing the difference between the global peak and the local minima throughout the day. Okay? And here are the results. When you actually simulate this algorithm, you get a very surprising insight. Again, purple is the current state. The dashed is the retrospective cheating, right? The yellow is a realistic schedule that you can accomplish. And strikingly, that realistic schedule is maybe one share apart from what you could do when you cheat, when you know everything in advance. So that's actually very surprising. We were optimistic, but we were not that optimistic. And in fact, that actually raises some theoretical questions, because it seems that if you do certain relatively simple rules, you actually don't need to know all the appointments in advance. You can actually realistically schedule and nevertheless get to something very close to what you could do if you had unrealistic assumption when you know all the appointments in advance. Now, so everybody's happy now, but now you need to implement this. And now you start to hit the realities of healthcare. First of all, you need to change the scheduling team structure. That's an organizational change. Currently, they belong to two different parts of the clinic that don't really talk to each other very well. And then you need to worry that maybe you are not, by making change like that, you're not affecting negatively on many other resources, like the pharmacists. They need to mix these drugs. Chemotherapy drugs are being mixed. And then you want to actually implement it into the current IT system, the electronic medical record. This actually was an interesting timing, because just parallel or just before that, there was a major change in the hospital when they installed the new system. And I have to tell you, if there is one regulation that I think policymakers should do here and in the US, is to force any electronic medical record vendor to create a stable API that allows other applications to integrate with it. Because currently, vendors are doing conscious effort to actually make it not work, because that helps their business. But that doesn't help patients. And it doesn't help innovation in healthcare. Because you can have a great idea, but if your scheduling tool cannot talk reliably with the existing AMR record, medical record, system record, that's a very nice slide. So we had to work for 2 years to develop an add-on solution that even now can only talk one direction with the current system. Because basically these guys are doing effort not to allow others to integrate with them. And it is not only Epic. I think it's a common thing. And I think that if there is one important regulation that policymakers should do, is to force and mandate. Because frankly speaking, I believe that innovation will come from the industry and from outside people from the outside industry. These guys are creating barriers for a lot of good ideas that basically cannot be implemented. Or the cost of implementing them is like unbearable. But we launched. We actually launched in April. The system is in use. It's going to be scheduled to actually, it's going to be used to schedule all the patients in the main campus center as well as in another satellite center. It's very exciting. We're going to monitor the results, and I hope that in a year from now, I will be able to draw another line which will be the actual, the impact that we actually made. It took 2 years to implement this, from the moment we knew what the idea is, what the solution is. Okay. Second example is work that we do with the surgical floors in the hospital. You have here a map. The green are the different surgical services. The blue and the oranges are the different floors and their capacity. These are highly utilized floors, and patients are waiting in those floors for beds on those floors in different locations. They can wait in the emergency department. They can wait in the recovery area after a surgery. They can wait in another hospital when they need to be transferred to the hospital. They wait for these beds because these beds are highly occupied, highly utilized. Our project focused on a subset of the floors and some regular floors and some ICUs. And our focus was to try and see if there is something in the way we allocate these beds to patients throughout the day that can actually reduce what we call the intraday wait time of patients to beds. Now, you want to measure this. So you start to sort of see, okay, analytics. Like, let's just look on all their electronic medical records in the hospital, and let's try to understand how long patients are waiting now, right? So let's define wait time as the time between the patient is actually ready to move from one location to the floor until the time the patient is actually moving, right? That's one natural way to do that, right? Okay, so how do you know when the patient is medically ready to move? Well, very natural assumption would be, let's just look on when the bed for that patient was requested by the sending unit, right? So if you just want to do analytics, you can run analytics on that, but you're going to get very wrong answers. And the reason is that you need to understand the process that generated the data. One thing that I think we miss in analytics, we all the time look on the data as is. We don't understand that this data was generated by a given system, by a given process, by humans. And the data generation is affected by human behaviors. Now, if this is a very utilized system where people know that the patient will wait a long period of time, they are very likely to actually put the bed request into the queue far before the patient is ready. If you don't understand that, you're going to interpret the data completely wrongly, the wrong way. Now, so we did a lot of effort to actually understand this. So that was actually a lot of effort to really use multiple signals to understand when the patient reasonably, reliably is ready to move. Okay? And then we mapped the current bed assignment policy. Actually, it's very hard because a lot of the time it's not documented anywhere. It's actually some set of internal rules that can change day to day based on the people that are there, right? And again, this is a policy that generated the data, right? Here are a few insights from what we learned. Beds were assigned to surgical patients not when they were ready, but actually based on their surgery time. As a result, there were many cases in which patients were waiting for beds ready to move while these beds were already assigned to patients that were not even in their surgery. The discharges were managed manually, and most of them were happening very late in the afternoon. And that created a mismatch between the admission requests that kind of started to accumulate over the time of the day from the morning, right? And created other problems. So what did we want to do? We wanted to actually change and use a concept from supply chain management that is called just-in-time, change the mindset to really assign patients to beds only when they are ready. And also, minimize the number of requests that are not necessary. And really there was a group of patients that called PPR patients that basically, most of the time they didn't need the bed, but because people were conservative, they requested the bed was saved for that patient until very late in the day, and only then was released. Now, that's great, but I have to tell you, people will get very suspicious if you want to change that. They will tell you, oh, how do you know that I will have the bed when I need it? Because a lot of the time they allocate these beds because they are conservative. They know that this patient will need the bed. They want to not worry about this anymore, so they make the early assignment, right? So we needed to build a simulation model, very, very complex one, to actually simulate this very, very complex system. It took us good 6 months to actually get there, because this was, again, uncovering all the implicit rules that are taking place. Now, one of the other things that complicated things here is that MGH has many rooms that have 2 beds in them. And that creates another layer of complexity, because if you have a female in the bed, you cannot put a male in the bed, in the other bed. If you have someone with an infectious condition, you cannot put someone that doesn't have, unless they have the same infection condition. So many beds were actually closed because different reasons. And you had to actually simulate and understand all of these aspects in order to actually be able to leverage the analytics. And we did that, and we actually implemented this several months ago. You see here multiple things, the distribution of the wait time of what was historically in 2015, what was simulated at the time, what was the actual performance in 2017 before we actually implemented this. But to cut things short, we actually reduced the wait time of patients in all places by 30%. Same number of beds. Same number of beds, no additional resources. Dramatic impact. The way to convince that was to really show them, based on data-driven simulation, that it's going to work. And then use the leadership, right? The leadership to actually try it out as first 4 floors. Now we are actually scaling it to all the surgical floors, and hopefully with the attempt to actually scale a variant of this to the rest of the hospital. Okay. Now, another thing that I told you about, that many of the discharges are done manually now and actually are not known in advance. So we actually decided to see whether we can predict who is going home. And in order to do that, we actually are able to leverage extensive data. Basically, we look on every clinical order and a lab result that was administered for the patient. Not only that, we actually look on the case management. Case managers are people in the hospital that actually manage the discharge of the patient. If they need social services, if they have some problems, if they have some socioeconomic problems, we actually text mining their notes. And we basically train predictive model based on a technology that is called deep learning that basically outputs the 30 most likely patients to live in the next 24 to 48 hours. This is still ongoing work, but let me show you some initial results. These are the predictions to December. Basically, this is the number of patients in every day that we predicted 30. How many of them went in 24 hours? How many of them went in 48 hours? How many of them actually stayed longer than 48 hours? We have 85% accuracy. And we are not even using all the data that is available. This is a game changer. Why? Because now, instead of waiting for the floors and physicians to report when a patient will go home, that's the common practice. It doesn't work because physicians are not very good at this. And B, actually the floors don't have a real incentives to report that very early because they know if they report on a discharge, they're going to get immediately another admission because it's a very, very highly utilized system. But now we don't need to ask anybody. We can tell the data and have a decision process that will actually help us. I want to finalize with final exam is heart failure readmissions. This is a very common issue. How to prevent readmissions of heart failure patients. What is a heart failure? It's a condition of the heart that basically makes the heart not pump blood very well. It's a chronic illness that becomes an epidemic, like many other chronic illness, that has a gradually deterioration of the condition of the patient over time. Just to give you a sense of the prevalence of that, 900,000 new cases in 2030, 1 million annual hospitalization, projected cost $70 billion just in the US. Big issue. And one of the things that now hospitals in the US are penalized for is if the patient was hospitalized with heart failure condition and came back to the hospital within 30 days, you get a penalty. So everybody is trying to reduce that. And I would want to argue that that's actually the wrong problem definition. This is data of the admission days of the hospital of heart failure admissions in 2014 and 2015. What you see here, the total number of days went up, the readmission days went down. But the definition of the readmission problems is this is a hospital-based problem. However, most of these patients are actually never were hospitalized. They are being managed in the outpatient setting. And in fact, at some point, they become sick and they get hospitalized first. And after that, they keep coming back. So in fact, when you look at it this way and you now redefine the problem to prevent admissions, you actually get what I call a system, an outpatient-based problem. Problem definition is very important here. If you think about managing chronic conditions, this is not about readmissions. This is about really keeping these patients at the outpatient setting by identifying them, by knowing what the care they should get by whom, and by having systems that monitor and escalate, that are being supported by system and processes and being supported by decision support tools and risk models. This is something that most hospital systems do not have. It's completely broken. In fact, we actually know that over 50% of the patients that arrive to the ED, emergency department, and get hospitalized with a heart failure condition never saw an outpatient clinic in the 2 weeks prior to their arrival to the ED. And we know that heart failure condition is something that deteriorates over time. You don't like wake up one day and need to go to the ED. In fact, if you intervene over the course of these 2 weeks, you can actually prevent the admission very likely. We actually build a model that tries to predict who is likely to be first admitted to the hospital. And interestingly enough, the predictive factors are not necessarily clinical. You have a lot of things that have to do with the language, if they don't speak English, if they are single and don't have family support, the kind of drugs that the doctors are giving them, and so forth. Actually, this model has a very strong predictive power. So let me just finalize and give a room for questions. What I want to emphasize is, when you want to innovate, you need to work on top priority issues. Data is very important, but it's not sufficient. That's very important, right? You really need to understand the system-level problem, do the diagnosis, and what are the real constraints that people act for. What is the rationale of the current system? And use hypothesis testing of experts to actually match it with the data. Leadership engagement is key. You cannot implement anything if you don't have the support of the most senior leadership. And you really need to translate the problem into a decision support tool that helps people to see trade-offs and what if. Thank you very much. I am happy to answer questions.
Let's see, we have questions from Twitter. Do we? Let me ask a question before they put these questions on Twitter. It is very clear from what you are presenting that this is not only could be done in a country like Chile, but this should be done in hospitals in Chile. Absolutely. So first I would like you to tell me whether or not you confirm that statement. But second, what are the resources that a hospital will need to devote to be able to not necessarily replicate, but use some of the tools that you have done to be able to do them here?
That's a great. So first of all, I absolutely believe that this is something that every country should adopt. I think that Chile has good universities that could actually engage in that and be good partners in that. I think that from a hospital perspective, they typically think about the cost of paying for the resources of the university, but to me, the most significant cost is the internal organizational attention. This cannot be like a hobby. If you're going to work on this, this is the problem that nobody wants to work on, we're going to let some professors and students to work on, that's not going to work. Actually, that's a no-starter. You need to be able to build the infrastructure that provides the data, provides the clinical and administrative expertise, and it's really working together in one team. All of our projects are done in integrated teams of faculty, students, physicians, and leaders under the supervision of the senior leadership of the hospital. So that takes attention. So this is why you have to work on top priority issues. But you also have to be willing to pay attention to this and believe that this is a long-term strategy to actually change.
So, can I do a follow-up on that?
Yeah.
So, if you have to put a share about how much is the time devoted to research, how much is time devoted to changing the organization, how much time is required from the attention of the leadership, and so on. How will you distribute these times, especially with your experience in MPH?
Yeah, I think that the last 2 points are the most significant time share. Usually it takes you, let's say, half a year to know what the problem is and what the solution would look like, and then 2 years to implement, because it's very complex. It's very complex. And these systems don't have patience usually. we are very action-oriented. If you come and say, oh, it's going to take us 6 months, they tell you, oh, no, we need it next week. This is a problem that existed for 20 years, but nevertheless, they want the solution next week. Sometimes you need to say, yeah, no problem. We'll see what happens. And, sometimes say, it takes whatever it takes. You can say that you want it, if it takes a year, and you said that you want it in 3 months, it will still take a year, because it takes a year. But I think that there is a patience issue sometimes. You need to kind of get a different tempo in the organization.
So I don't know if these are questions, but...
I think there is one question
I do
here.
have a question. Yes. I'll translate.
No, related to your answer, how did you start a collaboration with the Mass General? I mean, was their initiative yours? I mean, in terms of
Yes, the question
Yes.
is how Retsef started the relationship and the collaboration with MGH.
That's actually a funny story. We started to work with them very informal way. The data was not there. So at some point I told them, you actually have to pay for the resources and show commitment. And their first reaction was, there is no way we're going to put a cent on this. Go back to your office. We call you. Don't call us. And everybody told me, oh, just cut your losses, go. I'm an Israeli, so I'm a little bit stubborn. So I came back to them and said, you know what, let's just do a pilot for 2 years where every dollar that you put into this, I will bring $1. I didn't have money, by the way, but what I plan to do is that if they tell me yes, I will go to the dean and tell him, oh, these guys are willing to put some money in, let's just match it. And that's what happened. They put like 100K. We put 100K for 2 years. After that, they currently pay about $1 million a year on this, completely funded. After they saw the value, they basically don't have doubts now. They increase the spending on this every year.
Now, let me rephrase that question. Did all your research actually was paid off by efficiency gains in MGH?
I think that by now we saved, at least on one thing, we saved like 10 million a year. So yes, the answer is yes.
You have saved 10 million a year.
Yeah,
Okay, good.
I think at least, I think it's paying, at least paying off the thing.
Thank you so much. Thank you so much. Thank you.